when you look at the ADA and the ACE guidelines tied in with diabetes and treatment standards, there is a suggestion you start with monotherapy when the hemoglobin A1C is less than 7.5%. They suggest increasing as dual therapy as you get above 7.5%, as long as you're less than 9.0%. They suggest that all patients that have a greater than 9% hemoglobin A1C get treated with insulin. I think we're now starting to see, through the various problems where diabetes is coming from, there are so many things that we revealed through things like Ralph DeFronzo's Omnis Octet, that diabetes is a complex disease state, and treating with one medicine may or may not make the best of sense, because you have multiple mechanisms that you need to manage, and no one drug will take care of all the mechanisms. Regardless, these standards are there. I'm going to suggest we take them to another level. In my clinic, we have an average hemoglobin A1C of 5.7 over an 8-year period when it was recently data mined by an outside entity. Each year of those 8 years, we had a hemoglobin A1C average of 5.7 in a large number of diabetics totaling over 3,000 patients. How are we able to get a tight control like that without causing patients profound hypoglycemia? Well, number one, I don't use sulfonylureas in hardly any patient, because that generally makes it difficult to have tight control without precipitating the potential for severe hypoglycemia. I recommend using drugs that cause no significant severity of hypoglycemic events. My first goal in the treatment of diabetic is to turn off that genetic expression, and thus I said previously, I'll say again, I believe Actos is probably the best first-line drug in a type 2 diabetic, because it downregulates the genetic expression. Here again, the water's leaking, you're mopping, why would you not want to turn off the water source? The diabetes is leaking, you've got a genetic expression, why would you not want to turn off the genetic expression? Pioglitazone is effective in doing that. We learned from the diabetic prevention trial that proper diet, including reduction in carbohydrates, makes a significant improvement. But if you look at the diabetic prevention trial and the arm that had strictly diet and exercise versus the arm in that study that got troglitazone, the troglitazone arm had the more significant reduction in patients going on to become diabetics. Putting the two together is the proper cocktail, though. Secondly, I want to make an emphasis on inflammation, because it's not the sugar that hurts the patient, but it's the inflammation related to the sugar. Now, if I'm watching those target organs and those specific biomarkers we just mentioned, and I'm also looking at the generalized inflammatory response with the hs-CRP and the fibrinogen, and also the chronic inflammatory response with the plaque-2 and the myeloperoxidase, combining that information, I'll know if my diabetes cure is complete. For instance, if you had a hemoglobin A1C of 4.9, but you had a fasting insulin level of 26, and you had the patient on 2 medications, maybe 3. Let's say you had them on pioglitazone, metformin, and Bydureon. Even though that patient's hemoglobin A1C is 4.9, that fasting insulin level of 2.6 would suggest that this patient would benefit from adding Levemir or Lantus basal analog insulins. I would start the patient on 8 to 10 units and increase the dose by 2 units every single day by measuring their fasting blood sugar until their fasting insulin level consistently was under 100. For instance, if your fasting blood sugar today was 130 and we gave you 10 units of Levemir or Lantus yesterday, I would suggest we would go to 12 units, adding 2 units, because your fasting sugar is over 100 at 130. The next day, if your fasting blood sugar was 115, we would increase it by 2 more units, from 12 units to 14 units. The next day, if your fasting blood sugar was 105, it's still over 100, we would increase it from 14 units to 16 units, but the next day your blood sugar fasting is 88. I would then keep the Levemir or Lantus dose at the 16 units that got me there. If you wake up one morning and the fasting insulin level was less than 70, in that particular case, you would lower the dose by 2 units of Levemir or Lantus. So if you were at 16 units, you would lower it to 14 units. So by titrating the Levemir or Lantus dose up or down based on where your daily fasting blood sugar control is, you can maintain a rather good state of control of blood sugar for that patient, and usually that results in improved inflammatory responses. If that patient is eating carbohydrates carefully and exercising, the responses can be phenomenal. Thus, the average hemoglobin A1C at my practice is 5.7. You certainly, as a fourth-line drug, might consider using an SGLT2 drug, allowing for some reduction in this glucose through the kidneys. There are several other ways you can do this from this process. If you had a complicated patient with insulin, you could certainly consider using an insulin pump, along with the consideration of Actos and a GLP-1 analog, if indeed you wanted to attempt to reverse this type 2 diabetes condition. If you were to line up 100 patients and say, if I had it within my power to reverse your diabetes condition, would you like me to try? I think 100 out of 100 would say absolutely, because nobody embraces diabetes. Nobody says, oh, I love my diabetes, please don't take away my diabetes. I love my diabetes. My dad had diabetes, my mom had diabetes. I want to be a diabetic. You don't hear patients say they would love the potential to reverse it. And while we don't have the proof in people yet that you can do this from a scientific study basis, it certainly appears from animal data that it is possible. It certainly appears from the almost 300 plus patients in my clinic that have come off of medication or have decreased medication substantially that you can do it. I think studies in the future will tell us for sure, but until that time, making a strategy where you downregulate the genetic expression while you improve the beta cell function always makes sense to me. I'm going to control their carbohydrates, watching very closely the Smaldens LDL, watching very closely those panels with glycemic control to see if they're cheating on their diet after the meal. I'm going to look at that adiponectin level to see if they're consistently eating carbohydrates, because remember, if they are consistently eating carbs, their adiponectin level will stay above 45. If it's less than 16, they're doing pretty poorly. I'm at that point using that strategy for reversal of disease, and then lastly, you want to control the LDL-P and ApoB in these patients. You see, if you've got good control of the diabetes, and you've got very good control of the inflammation-related diabetes, and you've got very good control of the cholesterol, now you've got a patient that not only is not getting their blood vessels damaged by this disease, you're looking at a patient who's having reversal of disease where plaque regression can take place. If you look at the genetics tied in with this disease, there are some big things coming out recently. ApoE testing is talking about a patient's condition and what kind of fight you're fixing to get into. I used to play tennis, and if I was going to play you in a competitive tennis match, I would watch you before the match, and I would assess where your strengths and weaknesses are, and I would come up with a strategy how I was going to overcome you in a tennis match. It's the same thing in diabetes. If you see a patient's ApoE status, you're starting to know what kind of fight you're fixing to get into in this process of care for the patient. If their ApoE status includes an ApoE2 from one of the parents, you know that there's going to be a higher propensity toward triglyceride elevation and problems that could relate to insulin resistance in these patients. ApoE3 status has to do with normal lipid metabolism, and these patients can do well if they would just eat right and exercise. However, an ApoE3 patient can have heart disease if they don't eat correctly. When you see a patient with an ApoE4 from either parent or both, now you have identified a patient that's an extremely high-risk patient. They tend to have higher levels of inflammatory reactions, higher levels of atherosclerosis, because they tend to have higher circulating levels of LDL, the bad cholesterol. Alzheimer's syndrome is more common in these people, and thus I think we'll be watching for ApoE4 status and how the leptin to BMI ratio coexists, because certainly there may be a means of detecting things that touch on as much as 80% of Alzheimer's disease developments if we're watching these areas. MTHFR genetic defect, in my opinion, probably the biggest medical discovery in the last 10, 12 years. This genetic defect has to do with your inability to turn folic acid into the fifth breakdown product called methylfolate. These patients lack an enzyme, methylene tetrahydrofolate reductase, and when they lack that enzyme and they can't make methylfolate from folic acid, now you have an inability to make certain brain chemicals. Specifically speaking, you have difficulty making serotonin and melatonin from the tryptophan and dopamine and norepinephrine from the tyrosine. BH4 applies into this because this same enzyme that was deficient in the breakdown of folic acid into methylfolate is also needed when methylfolate combines with BH4 to make these brain chemicals. And thus it's a complex process, but suffice it to say, these patients that lack serotonin, melatonin, dopamine, norepinephrine, they have difficulty with sleep, trouble getting to sleep, trouble staying to sleep. They sleep lightly. People can walk across the room, wake them up very easily. Their memory can get worse, especially with aging process. They have problems with concentration and focus. If they're homozygous for this defect, they'll have effects like attention deficit disorder as a young kid. If they're heterozygous, by the time they get about 35, they're having an ADD-like pattern as an adult. These patients lack motivation. They have problems with drive, getting things accomplished. They might leave piles of work. They start a project only to get distracted and start another project. As they get older, they become more withdrawn. They'll go do their work so they make income, pay the necessary bills. But once their employment's done, they tend to go back home. They prefer to be alone, but they will be with a family member if need be. But they don't tend to enjoy the things that they used to do. Patients that lack these brain chemicals have difficulty time because they don't have the ability to make their neurons do what's needed without adrenaline. Adrenaline is usually only high in normal patients when they have a flight syndrome for 3 to 4 minutes after you see something like a snake or a rat or something that startles you. But these patients with MTHFR genetic defect have high levels of circulating adrenaline 24 hours a day, 7 days a week. That is an inflammatory process of a big nature. We just talked about diabetes and inflammation. Now we're talking about this genetic defect and inflammation. And if you were to look at the two together, they both produce what seems like similar levels of inflammation. They both cause a lot of damage. For you to fix and reduce that adrenal level, you're going to have to fix this chemical balance in the brain. And to do that, you're going to need to get the patient on Deplin or 15 milligrams of an L-isomer methylfolate. That will, in studies, reduce symptoms of depression. It will improve this patient's ability to make chemicals over time. The patients with the MTHFR 677 defect tend to get much better in about 8 weeks. And I encourage you to go on to www.straighttotheheart.info and watch Deborah's story and how she got better with treatment. There's also an MTHFR episode that further explains this in more detail. If you've got an MTHFR genetic defect that's of the 1298 variety, these patients are harder to treat. While the 677 allele patients from MTHFR get better in 8 weeks, MTHFR 1298s don't get much better until about 18 months. At 3 months, they start showing some improvement in sleep patterns. In about 6 months, they will tell you their memory and concentration is a little better. At 12 months, their energy is better, but not enough that they would write home to their parents about. But at 18 months, if they continuously take the Deplin 15 milligrams one daily, they will actually have more energy, better memory, less withdrawn, less moody. They'll actually start leaving the house and doing things voluntarily because they're actually enjoying things that used to be fun to them. If your patient is heterozygous for this problem, they may have a 71% capacity to make these chemicals when they're born, but by the time they're 30 or 35, they're only making about 30% of those chemicals, and certainly the number continues to decline. By the time they're 60 years of age, they're probably making less than 10% and really struggling with brain chemistry. These heterozygous patients will have a high propensity toward birth defects in the women giving birth to babies in the 30s and 35 year of age range. MTHFR genetic defect is probably the #1 reason for birth defects such as Down syndrome, autism, and spina bifida. If your patient is homozygous and female and gets pregnant, obviously this is going to be a problem with pregnancies even at earlier ages, and the potential for miscarriage and problems with birth defects. These patients that have MTHFR genetic defect, not only do they have problems with high circulating adrenaline levels, they also have an incapacity to make nitric oxide in large quantities. Now, nitric oxide is responsible for dilating arteries. Adrenaline is responsible for constricting arteries. So if these patients are circulating high levels of adrenaline, let's say they have a blood vessel that's about 50% blocked, and now the adrenaline is constricting that 50% clogged artery. Now you have a 90 to 95% blocked artery based on the high circulating levels of adrenaline. In a patient without this genetic defect, they would be making levels of nitric oxide of a higher level to dilate these arteries, but these patients can't make much in the way of nitric oxide. Now, besides dilating arteries, nitric oxide actually stabilizes arteries and lowers inflammatory responses, and thus in an MTHFR patient, you're creating an extremely bad environment for blood vessels. If you take that same patient and you make them diabetic and you keep their cholesterol in a bad place, now you've got a recipe for disaster. Plaque development, inflammation all throughout the vessel, adrenaline constricting the artery, no nitric oxide to dilate the artery, no nitric oxide to make these patients' inflammation get better. Thus, we see this quite commonly, and it's something that we need to address more aggressively. This MTHFR genetic defect is probably present in about 60% of the patient population that you see, 6 out of 10. Some have the 677 variant, some have the 1298 variant. When they have both variants, the 677 and 1298 together, there's a high propensity toward more serious mental health issues. Of my patients who are bipolar, possibly as much as 80% of them are both MTHFR 677 genetically defective and 1298 allele genetically defective, and thus you can be bipolar without having this genetic abnormality. It's quite common to see it in both areas. I mentioned earlier the nitric oxide dilation in response to the adrenaline that is constricting these arteries. This is quite the problem, and imagine the potential for good here. You have a patient that comes to you with frequent and recurrent angina. You see that they have an MTHFR genetic defect, possibly a 677 allele. You give them Deflin 15 milligrams once a day. Their nitric oxide production increases rather significantly over the period of 8 weeks. This patient that's having frequent recurrent angina very well could be showing no angina and walking 2 to 3 miles with no angina in several weeks or several months, depending on the state of their blood vessels. Factor V latent and prothrombin mutation, genetic defects that have to do with problems with coagulation. These patients develop blood clots rather easily. These are the patients that go to surgery and end up 2 days later dying.